Welcome to this audio recording. This is a clinical approach, a hypothetical case discussion with questions that test the key concepts for a particular disease presentation. In this episode, we will discuss the case of a 55-year-old with a palpable mass in the right breast. A 55-year-old post-menopausal woman presents with a new breast mass in her right breast. She states that the mass has been there for about 3 months and has slowly grown in size. She first noticed it when she was taking a shower. The mass is not painful. She reports no nipple discharge, no nipple inversion, and no skin changes. She had her first menstrual period at 11 years of age. Her only pregnancy was at 35 years of age. Her mother and sister both had breast cancer. You proceed to perform a physical examination, starting with an inspection of the breasts. On physical examination, she has a 2 cm palpable, hard, ill-defined, immobile, non-tender mass in the upper outer quadrant of her right breast. There is no palpable axillary or supraclavicular lymphadenopathy. Question 1. What is the significance of her age in this case? She is postmenopausal. Breast carcinoma can occur at any age, but frequency increases at 40 years. A new breast mass in a postmenopausal woman is cancer unless stated otherwise. She is less likely to be affected by masses that affect premenopausal women such as fibroadenoma and fibrocystic disease. Question 2. For her history of the presenting complaint, what information would you like to know about the new breast mass? Some of the questions you'd want to know about the new breast mass include the location of the mass, since when the mass has been present, the rate of growth of the mass, whether it has grown rapidly versus gradually, is the mass painful, is the mass ulcerated, are there any other skin changes, does the mass shift position within the breast, is there nipple retraction, is there nipple discharge, is there a mass in the opposite breast. Common causes of breast pain include the luteal phase of the menstrual cycle, pregnancy, hematoma, cysts, mastitis, abscess, galactocele, and nipple fissures. Malignant masses are commonly painless. Hard fibroadenoma, also known as a breast mass, is commonly associated with shifting position. Swelling found in both breasts include a fibroadenoma, fibrocystic change, and breast carcinoma. Question 3. What questions would you ask her to determine the likely cause of the breast mass? Some questions you would ask her to determine the likely cause of the breast mass include her last normal menstrual period, her first menstrual period, her parity and last delivery, her breastfeeding history, history of oral contraceptive use or hormonal replacement therapy, history of breast or ovarian malignancy in her sister or mother, history of trauma to the breast, and history of breast cancer. All breast masses that persist through one complete menstrual cycle and all masses in postmenopausal women require evaluation. Remember that a normal mammogram or non-visualization of a palpable mass by ultrasound does not exclude cancer. There is a 5-time risk of breast carcinoma with a family history of breast or ovarian cancer. Additionally, there is a very high risk with BRCA1 and BRCA2 mutations. Nulliparous women and women who do not breastfeed also have an increased risk of breast cancer. Question 4. What additional symptoms do you need to rule out that would suggest that the breast mass is complicated? Some symptoms that suggest that the breast mass is complicated include a history of fever, a history of purulent discharge from the breast, history of weight loss, history of swelling in the armpits or in the neck, history of shoulder pain, back pain or abdominal swelling, history of coughing up blood or breathlessness, history of yellow discoloration of the eyes, history of weakness, impaired sensation, headache, or blurry vision. Fever, pain, and purulent discharge will indicate an infective process. Question 5. How should the patient be positioned to properly inspect the breasts? The patient should be examined in 3 positions. 1. Sitting with the hands on the hips. 2. Sitting with the hands overhead. And 3. Supine with the hands overhead. The best time to examine the breast is 5 to 7 days after the onset of menses. The breasts may be engorged before menses and during pregnancy, making examination more painful and less accurate. Both breasts are examined sequentially, both sitting and supine. Pressing the hands on the hips may bring out dimpling by putting tension on the breast ligaments arising from the pectoralis major fascia. Raising the hands overhead stretches the ligaments of Cooper, causing the skins or nipples to retract. It also allows us to expose the undersurface of the breast and examine the axilla. Question 6. What findings are you looking for in inspection of the breasts? For general inspection of the breast, we are comparing breast position, looking for any obvious masses, any visible swelling in the axilla or the neck, and swelling of the arms. Swelling of the arms may be due to lymphatic spread, postoperative axillary vein thrombosis, or lymphedema following radical lymphadenectomy of the axillary nodes. For inspection of the skin over the breast, look for ulceration, dimpling or retraction, pot orange, and dilated veins. Ulceration is seen in fungating carcinoma, cystosarcoma phyloides, and rapidly growing fibroadenoma due to pressure atrophy. Try to pass a probe beneath the skin. It is possible to do so in benign conditions but impossible in malignancy. Pot orange is a pitted appearance caused by cutaneous edema. The pitted marks are attachments or openings of follicles and sweat glands where the skin is firmly attached. It is seen in inflammatory carcinoma due to blockage of the lymphatic ducts. Dilated veins may indicate Monroe's disease, a huge abscess, phyloides tumor, or sarcoma. For inspection of the nipples, look for the presence or absence of nipples, the position of the nipples, the number of nipples, whether there is retraction, cracks, fissures, or nipple discharge. Circumferential retraction may indicate breast cancer since the tumor infiltrates and shortens major ducts causing retraction. Slit-like retraction may indicate duct ectasia with periductal mastitis. Bilateral nipple retraction may be congenital. Unilateral nipple retraction may indicate carcinoma or may follow fibrosis of a chronic abscess. For discharge, ask the patient to express. Also check whether retraction reverts as the patient attempts to express. For inspection of the areola, look for redness, shininess, and edema. Differentiate between eczema and Paget's disease when examining the areola. Paget's disease is unilateral and occurs commonly in older women. There is no itching and vesicles, and there may be destruction of the nipple and underlying lump. Eczema is bilateral and occurs commonly in younger women. Itching and vesicles are present. There is no destruction of the nipples, and there is no underlying lump. Unlike Paget's disease, it has a quick response to local steroids. Question 7. How should the patient be positioned to properly palpate the breast? Bimanual palpation should be performed with the patient lying supine with the ipsilateral arm raised above the head. Palpation can also be performed with the patient seated and bent forward. Question 8. What findings are you looking for while palpating the breasts? First, both breasts are palpated to locate the mass, looking for warmth and tenderness. Important details to note about the mass include the location and number of masses. The size is measured in 3 dimensions: the shape, margins, consistency, fluctuation, tenderness, fixity to the skin, fixity to breast tissue, and fixity to the chest wall. A mass with an irregular surface and ill-defined margins may indicate breast carcinoma. A mass with a well-defined margin and globular in shape is most likely a benign process such as breast cysts or fibroadenoma. A cyst is a collection of fluid in a cavity lined by epithelium or endothelium. Breast cysts are fluctuant. They can also occur in fibroadenomas, cystic degeneration in malignancy, or chronic abscesses. Fibromas have a firm consistency. Fibroadenomas are hard and feel like a pellet, diffuse shorty feel. Carcinomas are usually hard to stony hard. Cysts, lipomas, and abscesses are soft in consistency. For fixity, pinch the skin over the mass and see whether it moves. Breast cancer, traumatic fat necrosis, and chronic abscesses are usually firmly tethered to the skin. For palpation of the axilla, look for lymphadenopathy. If lymph nodes are palpable, note whether they are discrete or matted, whether they are fixed or mobile, and whether they are tender. Also note the consistency of the lymph nodes. Axillary lymph nodes are categorized into 3 levels based on their relationship to the pectoralis minor muscle. Level 1 nodes are lateral to or below the pectoralis minor and include the pectoral, subscapular, and brachial nodes. Level 2 nodes lie deep or posterior to the pectoralis minor and include the interpectoral and central nodes. Level 3 nodes lie medial or superior to the pectoralis minor and include the apical and supraclavicular nodes. With the shoulder adducted, forearm flexed, and resting over your forearm, push your fingers as high as possible into the axilla to palpate the central nodes. Then run your fingers against the anterior axillary fold to palpate the pectoral nodes. Run your fingers against the humerus to palpate the brachial nodes. Stand behind the patient and run your fingers against the posterior axillary fold to palpate the subscapular nodes. Then palpate the deltopectoral groove and superior to the middle third of the clavicle. Question 9. What are the differentials for a benign palpable breast mass? Differentials for a benign palpable breast mass include fibrocystic change, fibroadenoma, intraductal papilloma, fat necrosis, abscess, and galactocele. Question 10. What are the differentials for a malignant palpable breast mass? Differentials for a malignant palpable breast mass include ductal carcinoma in situ, invasive ductal carcinoma, invasive lobular carcinoma, mucinous carcinoma, inflammatory carcinoma, and phylloides tumor. Question 11. What is the most likely diagnosis for this woman? This woman most likely has invasive breast cancer. She is post-menopausal with a new palpable breast mass. Her risk factors for breast cancer include a family history in a first-degree relative and early menarche. The mass is non-tender, hard, ill-defined, immobile, and in the upper outer quadrant. Question 12. What investigations would you perform to confirm the diagnosis, grade, and classify the tumor? Investigations to perform include a mammography and core needle biopsy. This is part of the triple assessment of breast cancer, which includes a physical examination, imaging, and tissue sample for pathology. Imaging is done to rule out malignancy, multicentricity, and to screen women older than 30 years. Mammography is generally for women more than 35 years, and ultrasound for women less than 35 years due to their denser breast tissue. Ultrasound can also be used for needle-guided aspiration. Fine needle aspirate cytology is performed for cystic masses that are painful or enlarging. MRI is not indicated for the workup of a new breast mass due to its high false positive rate. Question 13. What imaging findings on mammography are suspicious of malignancy? Imaging findings on mammography that are suspicious of malignancy includes asymmetry, clustered pleomorphic calcifications, increasing density, and a new mass with irregular borders or spiculations. Question 14. What investigations would you perform following the diagnosis of breast cancer? A metastatic workup would include a liver function test for liver metastasis, alkaline phosphatase and serum calcium for bone metastasis, and a chest X-ray for pulmonary metastasis. Further investigations for metastasis include an abdominal and chest CT if the chest X-ray is abnormal or the abnormal laboratory values, bone scintigraphy for suspicious bone pain or abnormal bone studies, brain CT or MRI for new onset headache, visual changes or seizures, and a PET scan. Question 15. What surgical options are available for a patient with stage 1 and 2 breast cancer? Surgical options available for a patient with stage 1 and stage 2 breast cancer include breast-conserving therapy and simple mastectomy with sentinel lymph node biopsy only. Question 16. What are the surgical options for clinically advanced stage 3 breast cancer? The surgical options available for clinically advanced stage 3 breast cancer include simple mastectomy for a large primary tumor, simple mastectomy with axillary lymph node dissection if the nodes are enlarged or matted, modified radical mastectomy, and neoadjuvant chemotherapy followed by modified radical mastectomy, then irradiation for inflammatory breast cancer. Question 17. What are the contraindications to breast-conserving therapy? Absolute contraindications to breast-conserving therapy include multiple primary tumors in 2 or more quadrants, diffuse malignant microcalcifications throughout the breast, a history of chest wall irradiation, positive margins despite repeat excision, early pregnancy, since radiation cannot be given during pregnancy. Question 18. What are the options for hormonal therapy? Options for hormonal therapy include estrogen receptor blockers, aromatase inhibitors, or HER2 new receptor blockers. Question 19. What drug classes are used for chemotherapy in breast cancer? Drug classes that are used for chemotherapy in breast cancer include anthracyclines, alkylating agents, antimetabolites, and taxanes. Question 20. Which patients do not need chemotherapy? Patients that do not need chemotherapy include patients with carcinoma in situ, patients with small tumor, which is less than 1 centimeter with favorable hormonal and molecular characteristics, and patients with a negative sentinel lymph node biopsy. Question 21. What nerves are at risk of damage during axillary lymph node dissection? Nerves that are at risk of damage during axillary lymph node dissection include the long thoracic nerve, thoracodorsal nerve, medial pectoral and lateral pectoral nerves. Question 22. What is the most severe complication of lymph node dissection? The most severe complication of lymph node dissection is lymphedema. Axillary lymph node dissection is associated with a greater risk of lymphedema compared to sentinel lymph node biopsy. This is why sentinel lymph node biopsy is very useful. It prevents unnecessary axillary lymph node dissection. Lymphangiosarcoma can also occur in chronic cases. This is known as Stuart-Treves syndrome. It has a poor prognosis even after the limb has been amputated. That's it for today. If this was helpful, you can find more at hyperexcision.com. See you next time.